So we are here with Dr. Sarah.
Thanks for having me.
Yeah, it's fun. She's in Las Vegas. It's so exciting. Okay, so first of all, I'm kind of curious about you. Can I just ask you about you?
Sure.
Yeah. How long ago did you become a doctor?
Physical therapy.
Yeah.
Careful with those words.
Okay.
Okay.
Doctor of physical therapy.
I graduated physical therapy school in 2005 with my master's, and then they offered a doctorate program to go back, and I went back in 2008 and did it was a research kind of based doctorate, where I did a research project to be able to get my doctorate. And so that was in 2008, and did my research on the SI joint, which is fun. I love the pelvis, and so since 2008, so what year is it? 12 years?
So cool. I met you online. I looked up, I was looking up everyday movement. That's what it was. And I found you, and not shortly after that, you launched the PCES course. It's pre and postnatal now. Corrective exercise specialist. And it was a game changer as far as being able to add that information to Pilates. And there are a few common cues that Pilates teachers use. One of them is shoulders down, and the other one is belly to the spine. And you have some information for us about how we can give those cues in a more productive way, and maybe what some of the problems are with those.
Sure, that's a fun question. So I think in order to understand a cue, you have to understand the purpose behind giving it. So I think a lot of times the shoulders down cue comes in the face of you're doing something, and maybe their shoulders are coming up by their ears. So your goal is to get scapular retraction. And so you're doing some sort of exercise and you're shoulders down to keep them from being all upper traps. So I think that in and of itself is great. The purpose behind that cue is amazing. The problem is people cheat, right? They will do stuff how their body wants to finagle it, not your intended goal with that cue. And so I think there's nothing wrong with the cue. I think it's just making sure people are coming from the right place for it. And so often we might need to change our language a little bit or change our way of cueing to make sure people are coming from the right place. Because I often find that when you cue shoulders down, people become lat monsters. So they just will crank down on their lats. They'll crank down on their chest. So even if they're doing a scapular retraction type exercise, instead of it being mid traps and lower traps, so the whole point of the cueing shoulders down is to get more lower trap muscle. So if you'll just so when you cue shoulders down, the whole point of it is to get more lower trapezius. So what you want is this muscle right here working. And the problem is people end up coming from here, and then they end up coming from their chest. So if you'll turn sideways for me. Yeah. Perfect, there we go. So when people go shoulders down, they'll end up pulling down on their pec minor, because their pec minor comes in through here and inserts on the scapula, which is really cool. But not when we pull down, because that pec minor will pull down and it'll tip the shoulder forward.
Okay.
Then you'll end up getting some winging here. You might be getting some impingement in the shoulder. So with that cue, I really like to do back and down instead of just down, because I feel like back, here, turn again.
Yeah.
Thanks. It's perfect. I feel like back sets the system more for scapular retraction. So we get more middle traps, and then if you're already on that road, then you can bring in lower traps for down, and then you've accomplished your goal instead of making them tighter, instead of overworking the rotator cuff, because I find people who cue, and then what happens is your clients take that and they put that into, they're like, oh, shoulders down. So then they start pulling their shoulders down all the time during the day, and they end up overworking the rotator cuff, and I find they end up with huge knots under here. And so you can check them for knots. And then that ends up stopping the motion of the scapula itself. And so then they end up with shoulder pain, neck pain, and tightness. You're so loose, by the way. You feel great.
I am?
All this
Good.
movement. Yeah.
Hey.
Squishy upper traps. They end up taking that into their day. And then they end up very tight and painful, because what was a great cue in the moment, in that exercise, then turns into the snowball effect that then ends up making them really tight and locked down. So is that kind of what you were explanation-wise looking for?
Yeah, for sure. So we want to make sure that they're taking the shoulders back and then down.
So let's think about just as being, what's our goal? Our goal is to get more middle traps, more lower traps.
Okay.
So maybe saying, I want you to tighten here, focus on this muscle,
Okay.
and touch it, or show
Okay.
them on yourself versus pulling down.
Sure,
where it
sure.
becomes
Here, do
all-
it on. You can do it on me again.
Yeah. So saying, I want you to pull down here. So pretend you're pinching a pencil and then drawing down on the bottom of the pencil. So you want to feel it working right here instead of overarching, where they end up doing the work and cheating from their paraspinals. That happens a lot. And that way you're getting out of the chest. You're getting away from those pecs. Pecs are not, back muscles.
Right.
So we shouldn't be activating them when we're doing those type of exercises. And we don't want somebody to overuse their lats, especially when it comes to addressing postural issues.
Okay, so here's a question. When you have them get into those traps, how do you keep the ribs down? Because they want.
Well, so remember what I was just talking about cheating from the paraspinals?
Yes.
So when you move your scapula on your back, you move your scapula on your back, right? You don't move your spine.
Right.
So what ends up happening is when you cue somebody's scapula to work, arch and flex.
Oh,
And then extension. So when you ask somebody to move their scapula, they will often move their spine instead of come into neutral. Now go ahead and reach your arm over your head. They will move their spine, now bring it back down, instead of moving their scapula. So do that a couple times. You can see here how some scapula is gliding across our rib cage. So if you focus on scapula movement, not spinal movement, that is where they're usually going wrong there.
So that's a good thing, getting that.
Yeah, you want to get that scapula moving. You want to get the muscles surrounding the scapula very strong. You don't want to have the spinal muscles, those paraspinals often get so tight on people, overcompensating for scapular motion, because then you end up with lots of neck and shoulder tightness.
Yeah. Okay, and then where do these serratus come in?
Okay, so the serratus are amazing muscles. You can face that way. That'll work.
Okay.
Let me see your arm. So if you're here, scoot a little closer to me. Perfect. So the serratus. All right, just relax. There we go. The serratus are finger-like muscles that attach to your rib cage and your scapula, and they pull your scapula through. So when you think about reaching, like you're reaching for your coffee cup, you reach to drive the steering wheel in the car, these are reaching muscles. Now what they do is they, relax for me a little bit on the top, they flatten the scapula and pull it through on the bottom. What that does is opens the chest. Okay, so think about this is going to help with thoracic outlet syndrome, impingement, neck pain. So oftentimes women never work their serratus at all, and their scapula will kind of wing off their back, and they'll end up with a lot of tightness. Turn this a little bit more. There we go. They'll end up with a lot of tightness in their chest here, because that, you got a little tightness in that pec minor. Yeah, because they've got a little bit of tightness in their pec minor because it's overworking and their serratus is underworking.
So does that come from using the lats, overusing the lats, or
I generally find it comes from our hunched forward way
Just
of doing
when we do
things.
that, sure,
So we tend to come over the top versus through.
Got it. Oh, okay, sure.
Yeah, because we're doing like, look,
Right.
I should be sitting on my phone right now,
Right. Yeah.
So we get a lot of scapula elevation, and which ends up being a lot of upper traps,
Right.
a lot of chest, instead of coming through. Like think about where, way back when we would move around a lot more, we would probably reach up more for things. We would have varied motions instead of all of our forward technology.
Right. Yeah.
With hunched posture.
Hasn't
think about it from being kids, like sitting at our desk in school.
I know.
I mean,
never thought of that.
It's
idea.
hours and hours and hours and hours all day of reinforcing things. And then people wonder why they have aches and pains when they get to adulthood.
So, okay, so we got those, the serratus working, back.
And if you pull down, like you're talking pulling down shuts down the serratus.
Okay.
So that's where
Good
when
point.
you're asking if the lats stop it, you stop the motion of the scapula as soon as you pull down. Down is a very forceful motion for us.
Got it. Okay. So if
You can't
someone's
come
here
through if you're pulling down.
and okay, so that's a great point because I think where we get confused with some Pilates teachers get confused is their client could be here and they say shoulders down. My shoulders are not up that high. So if they're forcing them down.
I never cue shoulders down for reaching activities.
Okay.
Ever. So think push-ups, think pressing, think reaching. I never ever cue shoulders down. I like to cue shoulders neutral. So if somebody is wanting to come up here, then I usually will have them bring them down a little bit, but I'm usually very careful in my cueing to say, do not engage the lats. Do not pull down on your shoulders.
Okay.
Just relax them down.
Okay. Okay.
To usually give me a little bit more space, but without pulling down for it.
Got it. Good.
And then that comes by just explaining that and giving them awareness, because sometimes people just need to know where they should be.
Yeah.
And then sometimes you got to pull them in front of a mirror and,
You know, working with somebody and then you send them out the door. You know how.
And then they pick up on that cue and they're like, oh, she said shoulders down, so then they start pulling their shoulders down all day, and then they come to see me in physical therapy for a rotator cuff tear. You know, and I'm like, stop pulling your shoulders down.
Good point. Yeah.
You shut down your serratus. Now you created this impingement situation. No wonder you have bad fraying on your rotator cuff. I mean, most rotator cuff tears are not sudden tears. They're degenerative tears. They're in older women because we fray and fray and fray and fray, and we use poor scapula mechanics. And then you're like, well, why did this poor tendon decide to get shredded? I'm like, oh, well.
Over and over and over.
Yeah.
You said that you have seen these issues in Pilates teachers. Is that?
Well, we were talking about a flat thoracic spine. And I typically see, turn sideways, this is a flat thoracic spine, which everybody's like, ooh, look at this great posture. But the problem is I often find lots of trigger points in the rhomboids, and I see a lot of Pilates teachers. I just treat a lot of teachers in general because they tend to have the most complex problems because we try to fix ourselves. I mean, from physical therapists to personal trainers to Pilates, so it's not just Pilates, it's across the board. We try to fix ourselves, and in doing so, we create these very complicated problems, whereas a layperson hasn't tried to fix themselves quite so hard and developed so many compensations around something.
Okay.
And so I find teachers to be the hardest to fix, but the most interesting. I enjoy it. But often the most complicated, because we're trying to unravel ourselves, and we're like, how come I can fix everybody else? And I feel like I can't fix myself.
Yeah.
And it's because we know too much, and so then we end up with all these layers of compensations. And I think, I don't know, I just find teachers to be very interesting for a treatment standpoint, because it's a lot more straightforward than somebody who sits on a couch.
Right.
So back to a flat thoracic spine.
Yeah. Okay.
So you can see here how your thoracic spine is very flat.
Yeah.
And so when we talk about diaphragm expansion, and we talk about your diaphragm runs the whole way, right? And so when you think about this big diaphragm that's segmenting the upper and lower body, we think about needing it to expand in the back as much as the front. So oftentimes you'll put your hands underneath your ribs and say, okay, breathe into my hand. Good front diaphragm expansion, but the problem is a lot of times we don't get the same equal back expansion. So then you get a lot of tightness in the spine. So think about using breathing as your mini massage. It's your like open disc space, help everything feel free. And when your spine is this flat and kind of locked down, then you lose some of that. So
it should be more
kyphotic.
Yeah.
Push into my hand a little bit. Yeah, I also think there's a genetic component, because when I look at families and I look at people and then their spinal tendencies, and then we look at their tendencies toward prolapse, their tendencies toward what happens to their midline. Like, I really think there's a lot of genetics at play. Scoliosis. I mean, I think there's more genetics at play than we give credit for, and then we want to have these perfect spinal curves. We're like, oh, this is 10 degrees, and we're like, no, it's really not. There's a lot of variation and good, and so I really like to go on, is somebody breathing well? Do they have trigger points? Do they have pain? Are they tight? Are they uncomfortable? If so, then we need to change that curve. If they're not having any pain, any issues, they feel great, they don't have any tightness, then maybe that's just their normal variation.
Okay. So you have a breathing exercise in your course where you actually have, and maybe you could take me through it, because I'm thinking this would be good for me and anyone else. So how do
just
it's something like this?
Yeah. So when you basically pull your knees into your chest, your air can't go in your belly.
Okay.
And so this is perfect for people who are belly breathers, because then you can inhale into my hand. So yeah, we're gonna work on this. It feels very tight in here. Yeah. So you're actually getting more lower expansion, which is really good. So you're working there, but your upper back, I think, is fairly tight. Yeah, so you can see how you're wanting to go here instead of here. So it's really tight. So what I would do for you is have you do more hanging, reaching stuff. So let's picture you having a band around your arms. So, and you're reaching forward, putting resistance into that. So reach. Reach more. Reach
Oh,
more, reach
like
more.
this?
Yes.
Okay.
But through from the bottom. So kind of tuck your chin just a little bit. Let it come forward. Round into my hand. Round into my hand. Good. Now reach through your pinkies. Good. Now I would hold a band. So I would give yourself resistance into it, and then you can inhale into the band.
Okay.
So you can inhale into, so it gives you that kind of force to work against.
Sure.
And then you can get some really good inhale there. So when you reach, holding something, you engage your serratus. Your serratus also helps you inhale. Your serratus attaches to your ribs. It helps to spread your ribs apart. So you get a nice, big, full inhale.
Got it.
And so this can help you with serratus activation as well as, so go ahead and turn just a little bit more for me. And then inhale into my hand. Yeah, so you have great lateral expansion. I just watched your ribs come out an inch. That was beautiful. So what I would have you focus on, just because you probably have a lot of tightness, oh yeah, from being just a mom. There's just so many forward things that come with being a mom. And so you're gonna end up with a lot of trigger points here from all this forward task. And if we can get a more robust curve here, I think that would help with that. So what I would do is kind of scoot back. So let's see if we can do that full squat and hug your knees into your chest. Good, and kind of reach down for your feet so you put a stretch right here. Perfect. And then inhale into my hand. Ah, there we go. How's that feel?
Good.
Good. Like a nice stretch?
Yeah.
Yes, that's a really good way to target those tight muscles from the inside out, which I find makes muscles really happy, because when we're not kind of stretching them to death, we're using our breath, and I find your breath helps muscles not feel threatened. When we just crank on things and really stretch them hard, then they tend to feel a little threatened and want to lock down. But when we breathe into things, it helps us ease them without that threatened feeling.
So, next most common cue is belly to spine. That's our favorite thing to
Let's
talk
talk.
about.
Somebody's having a real issue with pressure management, pelvic floor issues. It's not necessarily that great for diastasis healing, because they're two different pressure problems. So they're two different abdominal support problems. So I find people with pelvic floor issues tend to be top-down abdominal control people.
Okay.
And so they tend to put a lot of pressure down. And so their lower bellies tend to bulge when they do things. And ribs tend to come up and down. So they'll often have a gripping line under here. So when you have them scoop, you can have them empty pressure from the bottom.
Right.
Versus navel to spine, where they will often maintain their belly pooch, which then puts pressure down on the pelvic. So when you cinch in the middle, you put pressure down. When you scoop out, you can empty pressure. So if it's cued right and for a purpose, then that can be good. Now for diastasis, I tend to see a lot of my women who are strong but still struggle. They've got these great flat lower abs and have all this control, but their ribs are stuck way open and out. So their external obliques are extremely weak.
Okay.
And so in people with pelvic floor issues, their external obliques tend to be overly dominant, internal obliques tend to be weak, and people with diastasis, their internal obliques tend to run the show, and so their ribs will open and spread.
Okay.
And they tend to have better lower belly control, and they tend to be like scoopers and drawer inners, and so having them brace more forcefully from the rib cage down can be really beneficial for that.
Okay. Okay, great.
So that's the way the external obliques pull on the rib cage versus internal. So internal crank open, external crank down and in.
Got it. Okay. What's like one thing somebody could do, a mom could do, like sitting down to activate her external obliques?
So when you think about external obliques, you think about the muscles that bring you down and across. So just like take your hand, put it in your pocket. Okay, these are your external obliques. So one thing you can do to work this is think about coming over and down.
Okay.
And so I find a lot of people that have diastasis, if you put them on the floor and ask them to do a crunch and ask them to bring their rib cage over, they can't do it. They can't. Their rib cage stays spread. They come from their QL.
Oh wow.
Interesting. So they have almost no external obliques, and I find those external obliques really help to support that system.
Okay.
And now you ask somebody with a pelvic floor issue to do it, and their rib cage is probably going to spread.
Okay.
I mean, their rib cage is going to come down too much, and they're not going to be able to come up spreading their rib cage, because their internal obliques are less active. So if you can teach them to spread their rib cage, then all of a sudden their pelvic floor just feels all of this relief. So it's kind of a cool, I don't know, it's fun to play around with it's all a pressure management issue, right?
Yeah.
So you just figure out where the problem is happening and where the pressure's going, and then you can find the solution. And so if you have somebody whose rib cage is really wide, we're going to want to address that. You have somebody who tends to go into this big anterior tilt, we want to address that. You have somebody with no lower abdominal control, maybe scooping would be the best cue for them.
Okay.
So it's basically a look at the person, what do they have going on. So the cue, navel to spine, wouldn't be a bad fit for half the people you're seeing. But I have seen women that have trouble engaging their middle TAs. And so there have been like 10% of people that I've seen where you need to do navel to spine.
Okay.
About 10%. but so sometimes I think we get hung up on what cues we should use and what cues we shouldn't. Instead, we should look at the person, you know? And so I think sometimes there's some issues when we try to package things and generalize them with like the always cueing navel to spine. Because you're right, I worked in a Pilates studio for a while and I heard that cue all the time in the background, and I was like, well, the person needs it. But so I think that's just something good to keep in mind.
That everybody's different. I think that's so great. Are you familiar with the difference between classical and contemporary?
A little bit.
So classical is basically like you stay with the order and you rarely deviate from that. And contemporary is much more free.
Yes.
So
I think most of my friends teach the contemporary.
Okay, yeah. Yeah, I do. I was trained contemporary. You were trained classical. Yeah, very classical, that's right. So contemporary is much friendlier when it comes to rehab, you know, with,
there's just so much leeway for
so that you can really teach people
well, and
just
you
to
think
move.
about what was the traditional for? It was for dancers, right? They were all in big anterior tilts. They all had big splayed rib cages. They needed lots of flexion.
So
I mean, you've got to look at what your population's for. So the traditional approach is going to be great for people with that body.
In the course also, you talked about the 3 different TAs, transverse abs. Can you kind of go through?
You know how much I love reading research. So when we look at TAs, then they actually get segmented out. And so you can activate different segments of your TAs. Now remember, a TA contraction is very subtle. Okay. So it's not very big. And so people are like, oh, contract your abs. You're pretty much getting everything. When people do a TA contractivation, it's very small, very subtle. But you can contract upper TAs, you can contract middle, and you can contract lower, and you can actually segment that out, which is really cool. So you probably have the body control as a teacher to contract lower abs. You can see I'm drawing my lower abs, but then my upper are completely soft and squishy. So I can contract lower TAs, firm, drawing in, and I can completely relax my upper.
When you contract the lower TAs, how involved are the pelvic floor muscles?
Okay, so this is one of those synergistic, like you see in nature, the symbiotic relationships. So the pelvic floor is not connected to the lower TAs physically. Okay, but through, I'm guessing, fascial connections, they tend to work together. So a lot of people, but not everyone, a lot of people, when you cue the front of their pelvic floor to work, because you can cue the front to preferentially contract prior to before the back. So when you cue the front of the pelvic floor to work, they're going to probably get a lower ab lift as well. So they're going to get those lower TAs on board. So working lower TAs, working on that lower belly pooch can help front pelvic floor issues. Which when we think about leaking, cystocele, things like that, targeting more the front pelvic floor, especially for somebody who tends to be a back pelvic floor gripper. It's a really good idea. And getting them to relax the back of their pelvic floor so it's not overworking, and getting the front on board. But they don't have to contract together. So I've seen people that are all abs all the time and their pelvic floor is just like hanging out doing nothing. And then I've seen people that are all pelvic floor and they can contract their pelvic floor a lot, but they have trouble getting their abs on board. So it doesn't always go hand in hand, but for most people it does.
Is it smart to teach people to?
I think it's smart to teach people body control. I think if you can do everything, I'm happy. So I think teaching is great. Because I think the more people can do with control of their body and feeling and actually sitting there and thinking about it, like, oh, can I feel the front of my pelvic floor contract? Can I feel my lower abs contract? Can I do that without overly gripping down on my upper abs? Probably not going to be an issue for your diastasis people, but will be an issue for your pelvic floor people, I bet.
Interesting, yeah. Yeah. So it's not, and I think that's really important to point out too, is that working with a student who has pelvic floor issues versus working with a student who has diastasis are going to be two different
Well, and the ones that
approaches.
have both, you're often going to see it be more a cause of leaking versus
Okay.
like severe prolapse.
Okay.
So, because it's going to be potentially more on the tightness side, because
Right.
the pelvic floor is going to be compensating for some of the abdominal laxity that's going on.
Uh-huh.
But
Okay.
I mean, there's outliers to everything.
Yeah, right.
So
Yeah.
you try to put a generalization on something, and then I'll see three people that are completely opposite. I'm like, well, there goes that theory. It worked for a while. So
Yeah.
I like to think about having people relax their jaw a lot, because if we want to think about our diaphragms freely moving, so we want this diaphragm to go down, we want our pelvic floor diaphragm to be very mobile and receptive to be able to work, not locked down. So if we're locking down our jaw and we're locking down, like if our tongue is pushing forward really hard, or completely slack, that can also cause an issue, I find, for getting the rest of our, just tendency over bracers as jaw clenchers.
So this is the
So it would depend on the person, I guess, to answer my question. So some people you're going to have to constantly cue relaxing, and some people, your mouth breathers, you're just going to be like, close your mouth, put your tongue to the roof of your mouth, and pull it back a little bit, and all of a sudden their whole system.
you just
is
take us
different.
through real quick, kind of like what happened and how you.
It was just one of those deliveries where things started to go a little wrong, and you have to push a little too hard. He had his hand stuck up by his face, and his chin wasn't tucked. So it was kind of one of those things. Your eyes right now. It was fine.
I had a C-section, so I'm like.
So the nurse is freaking out, and the midwife was not freaking out, thankfully. She was calm. So I was like, yeah, she's still calm. I'm going to be calm. But the nurse was like, what are we going to do? And she's like, we're just going to have her push harder. Clearly she looks like she's athletic. She'll be fine. So I think that in the delivery process, I have some partial tearing of some of my pelvic floor muscles. Deep pelvic floor muscles to help support organs, not superficial perineal tearing.
Okay.
And so in that, it creates a great environment for prolapse to be able to happen. And I went back to exercise too soon because, of course, I know better.
What's too soon? What was too soon?
I'm not saying.
4 weeks?
It's embarrassing.
4 weeks? 2 weeks?
So anyway, it's all about the person's body, but you really should respect your own body. And I just felt so great because I'd had such a great pregnancy and I'd stayed in such good shape and felt so good throughout the whole pregnancy that I was like, oh, I'm fine. Anyway, so the delivery itself caused me to have some prolapse because of all the excessive stretching.
Okay.
And of the fascia. So I just had really stretched out fascia, and I have a genetic history.
Oh, okay. Okay.
And I just underestimated the amount of rest I was going to need for fascia as well. Because I took my prolapse and I made it a little bit worse in the beginning.
Yeah.
So that was good. That happens to a lot of people, so you're not alone. Even when you know better.
Yeah.
You just think things don't apply to you until it applies to you.
Right.
So I totally get that. But it was good because in theory, I had been treating people with prolapse. And so in theory, I had helped lots of women.
Mm-hmm.
But when I really felt it was when I was like, oh, wow, there are so many little nuances that I did not think about prior to being able to feel it. So then I became my own experiment. And after I drug myself out of that depression pit, because that's what happens when you're like, my life is over.
And you can't exercise like the way that you were.
Well, yeah. Well, all of a sudden it becomes, I had this carefree life when it came to exercise, and now I have to manage everything, and that is just really devastating. And plus, there's just something about being a woman and having that part of you fail you after you're like, I am sleep deprived, I carried this baby, I delivered it, and this is my thanks. I feel like there's some part of you that kind of breaks where you're just like, why? You know what I mean?
Yeah.
It's just, that's hard. I think that's hard as a woman to put forth just all that hardship and the blessing and the wonderfulness, and I love my children. But it's still just a lot of work.
Yeah.
And to then have your body like not want to get back on board for you is just really tough to swallow.
Yeah, you're dealing with that, huh?
So my husband was like, Sarah, you need to just switch this off, put on your PT hat, and fix yourself, because if you can't fix yourself, no one else can. And I was like, oh crap, well that's a lot of weight. So then I got to work, and then I made myself better, and then I had a bunch of setbacks because I really like testing systems. And going hard. I'm just an aggressive person.
Yeah.
And so I managed to really heal it well. Like I went from a grade 2 to barely a grade half. And I can bear down, and it's not a problem. I can exercise hard, I can run, I can jump, I can do whatever I want. I don't wear any type of pessary or protection or anything. Like my pelvic floor is just strong and responsive and feels good. But it was an emotional, it was hard.
Yeah.
And it was a battle, and it was a fight, and it was figuring out what I needed, which was different from what other people need.
Right.
My tendencies and my background are different, and that's what I try to tell women is, I'm not sure exactly what you're going to need to fix this, but I know it's going to be hard, and it's going to be a journey. And as long as you're willing to stick with it, I will keep throwing ideas your way, and we will keep working on finding that solution. But you're going to have to stick with me with trying to dig deep to find that solution as well. Because that is one thing I found about healing the body, whether it's diastasis or pelvic floor issues or whatever it is that there's no one size fits all. And that's where it gets complicated. So when somebody says, well, that didn't work, so you're done. You're never done.
Yeah, that's for sure, right?
There's different levels of healing, so I just want to put that out there.
Yeah, sure.
So depending on genetics, your fascial just integrity, which is
age has something to do with it?
your age.
Yeah.
But I think a lot of genetics. I'm almost 40, so I feel like I'm still on that cusp of genetic. I wasn't like 20 when I got pregnant, had a baby. So I think that's where you get that genetics to play, and obviously our elastin gets less as we get older, so we have that against us.
Yeah.
But I also think that there's a recovery where it's functional, where you can do whatever you want, and maybe you still have a little bit of prolapse, but it doesn't get any worse, and it doesn't consume your thoughts. Put it that way, everybody with prolapse will understand exactly what I'm saying. It doesn't consume your thoughts all the time, and you can just live your life. And I consider that functional healing. Just when you look at the risk of surgery, I wouldn't touch anything that was like a low grade prolapse. And if you have pain, if you have like a grade 1 or even a grade 2, and you have all this pain, it's probably not the prolapse causing the pain. It's probably tightness. The uterine prolapse is a little bit different, but I think that working with more than one really good pelvic floor PT is where I would go, and I would get lots of opinions, and I wouldn't be afraid to get lots of opinions. I think that's where sometimes people go wrong. They just get shut down maybe by their doctor. Like, come back and let me know when you want surgery. And you're looking at the surgery risk and everything again. You're just like, why won't you send me to PT? Like, why can't we get this team? Like, somebody working with me that understands pressure management on the fitness side, that understands what I need from the wellness standpoint, and then get a pelvic floor PT that can help me internally, that can help tell me what I'm doing, and then get my nutrition on point where I create this great environment for healing, and get some sleep help with my child so that I'm sleeping so I can recover. So I feel like it's this, the full circle of, so I feel like if you pull out a couple pieces, then it's going to make healing so much harder.
As a Pilates teacher, you are that one person. And I always feel like Pilates teachers, we have more of a responsibility, because usually we see our clients two, sometimes 3 times a week. And if we're doing privates, it's a very intimate environment. So we have that ability to get the resources that are in our area, to be able to offer a list of pelvic floor PTs, of sleep.
It takes a village,
training,
right?
And
nutritionists. Whatever you need. If that's not something it needs to be and counselors. I send a lot of people to counselors because you've got to dampen that anxiety. You got to pull it down, and you've got to create this positive environment for healing. Because I've had a little over 1,000 women with healing postpartum problems, and the women that come in to see me that have this high level of anxiety, their results do not touch the women that come in that are just that quiet confidence. And they're just
Yes.
like, I'm determined. I'm, gonna do what it takes. And if this doesn't work, I'm gonna try something else. And when something fails, their whole world doesn't fall apart. They just get back on the horse, work on something new. And so they're constantly moving through their body, figuring out what they need, instead of completely falling apart every time something doesn't work and expecting somebody else to fix them. And then having those really high anxiety levels. So I feel like sometimes a counselor is actually the thing people need.
No, it's great. Yeah,
To
that's a
create
great
the
point.
emotional. So when we talk about all of those different things they need for healing,
Yeah.
the emotional side is also just as important as the physical.
Yeah, and thank you for agreeing with that, for sharing that, because some PTs, doctors, they don't believe that. I mean, they believe that it's the one physical
I've
or
worked
the
with
one
too many
medicine.
people where I've seen people that have exactly the same diagnosis, very similar things going wrong, very similar body types, and one gets right well in 2 weeks, and I'm like, what just happened?
Yeah.
I'm like, I am not, I'm the same person bringing the same things to these two people. Why is one still struggling a year from now, and I'm giving them the same things, and this person just healed themselves like magic? And I'm like, that's not me.
It's their emotional
It's
state.
what, yes, yeah. And so it's really interesting, but that's hard because as instructors, we just put the ball back in their court, which,
Yeah.
I mean,
Yeah.
that's a tough pill to swallow.
Right.
I do it a lot because I feel like people need it.
Yeah, for sure.
But it's a tough pill to swallow. But ultimately, if we're in this to help people,
Yes.
we need to give them some of those hard truths.
Yeah.
We
That
give them resources.
Yeah, for sure. So okay, well, thank you so much for letting me take you from where you're staying and for taking the time all the way from Boston.
This was
She's
fun.
here
Thank you.
while your husband is with your kids. And so thank you, teachers. Let us know if you need any follow-up, and we'll see you soon.